Good evening and welcome to the U.S. Lacrosse MedStar Health Lacrosse Sports Medicine Webcast. Tonight, ACL injuries. I'm Dr. Richard Hinton, Medical Director of MedStar Sports Medicine and Executive Member of the U.S. Lacrosse Sports Science and Safety Committee. Despite the concentration now on concussion and head protection in our game, the leading cause of lost game and practice time for lacrosse athletes continues to be ACL injury. Tonight, with the help of our expert panel, you will be able to recognize the signs and symptoms of ACL tears, understand the evolving concepts of treatment, and appreciate new ideas in injury prevention and rehabilitation. We certainly welcome your comments and suggestions from home as well as our live audience. We can be reached at home through Facebook and Twitter through hashtag AskMedStar. So again, we encourage your participation. On to our great panelists tonight. First, Dr. Karen Sutton from Yale University Sports Medicine and head team orthopedic surgeon for the women's U.S. national team. Next, Dr. Milford Marchant, orthopedic surgeon and head team physician for the MLL Championship Chesapeake Bayhawks and former national teams member. Justin Cooper, physical therapist and director of the MedStar U.S. Lacrosse Scholastic Injury Prevention Program for ACLs. And finally, Jay Dyer, strength and conditioning coach for Hopkins Lacrosse as well as the 4 national teams. So a great group of folks we have tonight. Karen, we'll start with you. Give us, the audience at home, a little bit of overview of ACL anatomy and why is it this ligament in particular is so often injured in jump, cut, twist, turn sports like lacrosse?
Sure, so lacrosse for all of us is a very exciting, it's a fast-paced game. And so it has a lot of cutting, pivoting, which is great for us playing as well as for us watching, but the ACL doesn't appreciate that as much. So it puts a lot of force on the ACL in terms of these high-speed games that have a lot of pivoting and cutting. Talking about the overview of the anatomy of the ACL, so the knee is made up of 4 ligaments. It's made up of the ACL, the MCL, the PCL, and the LCL. So the ACL specifically is the most common knee ligament that's operated on. So that's why we care so much about it, because it can be devastating to the athlete and take about 6 to 12 months for them to get back to their sports. What the ACL does is it prevents the tibia from shifting forward. So it protects the athlete and gives them some stability to the knee, both in shifting forward as well as twisting mechanisms. The mechanism of injury that usually occurs, there are 2 types. One would be a non-contact injury, and so that tends to be what you were talking about in terms of pivoting, cutting, a sudden change in direction. If you're marking somebody and all of a sudden they switch directions, your foot gets caught and it may hyperextend and a rotation may occur, and that puts too much stress on the ACL. The other mechanism of injury would be a contact injury, where it could be a direct blow or hit to the outside of the knee, and that can cause an ACL injury as well, sometimes complemented by an MCL injury and meniscus tears. So one of the things that we talk about for our younger athletes is predisposing risk factors for ACL injury. So there are some that we can prevent, but there are some that we can't prevent. So some of the intrinsic factors include just the shape of the knee. So when we see it surgically, sometimes the ACL is housed in a more narrow house, or the notch of the ACL can be more narrow. The next thing is sometimes anatomically women have a little bit wider hips, so they're at a greater risk for ACL injury because the Q angle, or the angle of the quads, has to go a little bit longer and a higher angle than for our male athletes. So there are some things that potentially we could prevent, or extrinsic risk factors, such as quadriceps and hamstring imbalance. A lot of times our athletes who are experiencing ACL tears have hamstrings that are weaker when compared to the quads. So that puts them at a higher risk for injury as well. Sometimes we'll also discuss footwear issues too.
I often hear in my office a family will come in with a young athlete and say, "Doc, is it the ACL?" If you could share with our audience, both here and at home, what are some of the basic signs and symptoms of an ACL tear? what's the history of knowing maybe whether that is an ACL injury or not?
So the history of the ACL, usually when an athlete comes in, if we want to diagnose it, we'll say, what happened on the field? Did you notice a pop? Have you had some swelling? Sometimes we won't see the athletes until about 2 weeks out after their injury. So we'd like to hear what happened on the field. So sometimes they'll describe a distinct pop that happened and then immediate swelling. They couldn't bear weight on the knee, as well as they had decreased range of motion. So that's something that they usually describe to us. And then when I see them, I ask, do you trust your knee? Is it something you feel like, can you walk down a curb, and do you feel like you're comfortable on their knee? And they'll say, yeah, it's just some pain that I have in my knee. So that may not be an ACL injury. But if they start to not fully trusting their knee, that's where I worry.
Great. Well, Milford, you've seen this game from a lot of different angles, playing at the highest level, taking care of the highest level lacrosse athletes. Mm-hmm. Surgery now has become the standard of care for ACL injury. If you could share with the audience sort of an overview of surgical intervention. Is it a repair? Is it reconstruction? We often hear a lot about, well, doc, which graft should I choose, a hamstring or a bone patella tendon bone? So
Sure.
Give us a few of the basics.
Sure, yeah. So just like you said, I mean, when the athletes come in, they may have an unstable knee from this ACL injury. And when I say they may, there is a small percentage of people out there that may or may not need surgery. We know that there's a whole group of people, and we call them copers, that can actually deal with their ACL injury in a non-operative way. Those people are few and far between, and I'd say probably less than 5% can do that. The majority of athletes, if they want to get back to participation, they need surgery. And so when we see folks in the clinic, for the most part, our athletes, they need a reconstruction. And that's different than a repair. When you talk about repair, you think about actually putting something or clicking something back together, sewing something back together. We know from the early studies on ACL and the early attempts to repair it, that actual, sewing the ACL back together was a horrible idea, or it failed miserably.
Right.
So since that time, we've gone to replacing the ACL or reconstructing. And I would say that probably one of the biggest advances that we've had in sports medicine here over the last 10 years is really being able to identify where the ACL is in the knee and its insertion points on the femur and the tibia. And so that our reconstruction techniques mimic the patient's native anatomy. And so in order to do that, though, we got to replace it. So we've got to take a tendon from somewhere and replace that ACL. You can take that from the patient themselves, or you can take it from a cadaver, or what we call an allograft. What we know from allografts, for the most part, is it's a good option. It's a very strong option. But from the literature that we have, we know that in younger patients, and that age tends to be below the age of 35, or somewhere around that range, that they have a higher failure rate. So for the most part, we use what's called an autograft, which you mentioned, hamstring or the bone patella tendon bone, the tendon in the front of the knee. Both are excellent choices. Both are very good options. And I think it's probably one of the biggest decisions that we have, trying to match that graft to the patient. If you Google ACL, I mean, you'll find a ton of information out there. Well, it's the same thing if we search our research database, the National Library of Medicine. You're going to find 50,000 articles on the ACL, and it's pretty confusing. I think that one of the things that we've really gone towards is trying to, again, match that graft to the patient. And both hamstring and bone patella tendon bone are excellent options. They both have equal success rates in terms of getting players back on the field. They have equal patient satisfaction rates. There are a couple there's a couple nuances between the two. But again, talking with our patients, those are the things we try to tease out so we can better match the graft to the patient.
One question I often get from patients is, well, it seems if there was a better way or a best way to do it, everyone would be doing it that way. But the sports medicine community seems to be sort of equally divided. Mm-hmm. So I'll put you on the spot. Primarily for a lacrosse athlete, high-end scholastic or collegiate player, you're more likely to do bone patella tendon bone or a hamstring graft?
That's a great question.
That's why you're on the panel.
It really is. I mean, I got to tell you, like I said, I think it's one of the hardest decisions that I make. With the fact that they both have good results with pretty equal outcomes. I mean, you can read the literature, from 2 years ago, and one will tell you hamstring's better.
Right.
And then you can read a paper from last year, out of Europe that says that the bone patella tendon bone's better. A lot of times when patients show up in the office, they already have a sort of a preconceived idea of what's going to happen. And that makes my decision easy because as part of this whole process, I got to get athletes back on the field. And so if their confidence in one particular graft over another is better,
So you might
that's
do,
what we go with.
You might do either in a lacrosse.
Absolutely. I think both in the men's and the women's game, both grafts I've done both, and so far with good success.
Great. Karen, do you have a go-to graft? Do you individualize it for each patient?
So mine is based by age as well as the competitive level of the sport. So if you're taking a 18-year-old female athlete who's getting ready to go to college and she needs a really stable graft, I probably will lean to a bone patella tendon bone graft. One of the main reasons as well is because a lot of female athletes have less strength in their hamstring compared to the quads. So I don't want to take more of their hamstrings, and so I'll focus on taking the graft from the quads or the patella tendon, as well as I just like the way the bone incorporates a little bit faster.
Okay. Justin, before we move on to you, one more question from our home audience. From chat roll, question is, which is more affected by ACL injury, men or women? And would you change your surgical intervention on female versus male lacrosse athlete? Either one of you guys.
Well, I think it's the literature would tell us that the female athlete, as Karen's already mentioned, seems to be more vulnerable in regards to ACL injury. I think that, and I think Justin has some of the statistics on that as well, but if you take a high-level female athlete who plays a competitive sport, whether it be lacrosse or or soccer or what have you, and you take them through a college career, their incidence for ACL injury is pretty great. I mean, it's a higher risk for ACL injury than it is for breast cancer.
Right. And Karen, I think the home audience, a lot of parents and players think, well, you get your ACL reconstructed, you're back on the field. We have another question from the at-home audience about this question of, is that it? Or are there long-term consequences of having had an ACL injury, a reconstruction, and going back to play? Can you expect problems down the line, or once you take care of it, you're done?
So the first thing I tell them is, you have your ACL surgery and you're done. My part's done, so I'm done. But then it's almost a 50-50 commitment from the athlete as well as from the surgeon. So there's a lot of work the athlete has to do in the immediate term. And then what you're talking about is the long-term sequela, too, of having an ACL injury and having it reconstructed. So we still don't have all the data out there. I think there is an initial hit to the knee when you have an ACL tear. So a lot of times on the MRI, we'll see some bone bruising there. We may have a meniscus tear. So I think part of the outcome is determined by the initial injury and what's happening. So is there an isolated ACL tear, or is there a lot of damage to the cartilage, a meniscus tear? And so that may predispose somebody to having arthritis later down the road. As well as we also have to look at the effects of potentially what's going on with the other knee, and are they at risk for the other knee having an injury?
I mean, the great thing, you and Milford, very successful, take care of a lot of high-end lacrosse athletes. As you get to be my age, those patients start coming back to you 15 years after you've reconstructed them, and you get to see that sequelae of arthritis in the knee afterward. Justin, we're going to move over to you, okay? Justin heads up the MedStar U.S. Lacrosse ACL Injury Prevention Program and really develops a lot of best standards as far as lacrosse and rehab of the lacrosse athlete. Share with the audience here and at home an overview of sort of that rehab process. How long and how often?
The rehab process after ACL reconstruction is lengthy and it's costly. And remember, this is a time when the athlete is away from their teammates, away from their friends, so it's significant to them. We typically start with 1 month of prehab, so we're preparing that knee to have the best outcome after surgery. Then we move into 2 to 3 times a week
So
of physical therapy.
prehab, so you're actually seeing the athlete before they have surgery.
In most cases, we want to see them in the clinic beforehand for some sports physical therapy to decrease swelling, improve range of motion, and increase strength as much as we can. We know the quadriceps is going to be inhibited after the surgery in every case. So the more we can build their strength, and really from their core to the floor, the more we can get them stronger, the better off they're going to do after surgery.
Is there some transition? I think the people in the audience always wonder what type of professional they should be seeing for their child's injury and rehab. Is there some transition between, say, formal physical therapy and moving to a gym program, say with a personal trainer, or coming back to see you less frequently for instruction, but moving out of physical therapy to a gym-based program?
Yeah, I mean, after the surgery, they're going to be in physical therapy for 2 to 3 times a week for those first few months to get their full range of motion back, to improve their strength, to get them back to the functional activities they need to live life. Walk around town and go up and down stairs and squat down. And then as they move into the return to sport phase, that's where that transition happens, where they're building their power back, their agility training, going from jogging to sprinting. And so there's a place for the sports physical therapist, the athletic trainer if they're with a team, or also a personal trainer to work with them to get them all the way back. And we know it's a long process. It's sometimes 6 to 12 months, and if our professional athletes take 9 to 12 months to get back, we can't ask our younger athletes to do something better than that.
Great. Well, look, you and Jay are sitting beside each other because the transition for the athlete is from you as physical therapist to Jay as performance enhancement. So Jay, what are some of the major concepts we read about? Look, it's not just treating the knee, it's treating the whole athlete. It's returning the player back to the lacrosse field in better shape than we found them when they first came in our office. So touch base a little bit on your overview of preventing ACL injuries with total body training.
Well, I think first of all, after Justin has completed his process with the athlete, the first thing that the parents and the athlete need to understand is that if you've been discharged from PT, it does not mean that you are ready to go out on the practice field and compete and try to react to your teammates. And the sport is very fast and very quick and a lot of reaction and change of direction, and that there has to be a component of doing that in a stable environment, so a training environment where you're allowed to progress into that situation long before you get on a field and put a stick in your hand or you're playing the game. So, and I think that that is something that a lot of athletes miss out. They think as soon as PT's over, that means, well, they said I'm cleared, so I'm ready to go, and they're just not physically ready for a 2-hour practice. The conditioning standpoint, the core strength is probably going to be lacking. Again, we've talked a lot about being quad dominant athletes. We still have to go through a progression of improving hamstring strength, improving flexibility, improving mobility, and also, like I said, give them the opportunity in a stable environment to work on reaction and work on change of direction and allow them to be, make them that much more confident in their abilities as they return to practice.
So a great follow-up question from the home audience, AT22, following up on that. How do you show these athletes when they come in that they need to develop that core strength, that they're deficient in core and hip strength? Are there exercises or things you try to have them to do that they just can't master? Or how do you convince them to buy in that they have some core and hip muscle weakness that needs to be attended to before they return to play?
Well, we have a basic program that we would do with an athlete that is, it's concentrated on hip strength and also core strength. And once we get them integrated into that and they start performing those exercises, it becomes pretty apparent that they're not where they need to be. But on the other hand, they also see other athletes that are quote unquote healthy athletes that are doing those same exercises to try and also prevent the type of injury that they've had. So they see it not only as injury prevention but also return to play type exercises where the first time they go through, when they wake up the next day and they're a little sore or say they couldn't even complete the exercises, it gets the light bulb to turn on.
Okay. One last question before we go to our live audience for a couple of questions. And Milford, you and Karen have seen this from the player's standpoint at a high level, and Justin, you and Jay worked with it every day. What is the last thing that the lacrosse athlete gets back? After they've torn their ACL, rehab, getting ready for full play, is it that sense of explosive power? Is it their speed? Is it mental confidence? What is it you think is the last thing to sort of gel before these kids are really ready to go on that knee? Any of you?
I would say two things. One is certainly proprioception, so that's knowing where your knee is in space. And if all of a sudden you were bumped one way or the other, which you typically aren't in physical therapy unless you have an aggressive physical therapist, then I would say that it's how your knee reacts to those situations. So that's very hard to deliver in physical therapy and strength and conditioning. So getting back to that in practice is really important, and really important to go slow with that. The next is building the confidence, and that's where I think working with our physical therapists and our strength and conditioning coaches to make them feel confident with it. And a brace won't really do the job. You can't really do that for them other than give them all the resources to get out there and feel very confident.
Because it's interesting, Milford and I were talking before we got started that our literature suggests that we give these kids a stable knee 90 to 95% of the time. But return to play for a scholastic athlete at the same level is only about 75%. So Jay, from your end, working with these kids as they're trying to get back on the field, what do you find is the last thing that they're sort of fully ready to go with?
I think that, in the position that I'm in, I give them the confidence to have the confidence in their physical abilities, but sometimes it's just the mental aspect of it, you have to get them to bring their stick in and learn how to do their split dodge again, or have how to cover somebody that's dodging them, or move well in the goal. And I've actually just done that with athletes. They have a trust in me, so I'll be the person to bump them around and move them around, and before the guy that's actually competing for a spot with them starts doing it. So. And they can accept that challenge, and it gives them that little bit of confidence, and then they can progress from there.
Great. Justin, from the home audience again, question on, give us a little overview of this concept of ACL injury prevention program. It's gotten a lot of press both in the lay and medical literature, and seems to be effectively decreasing the risk of injury, particularly in young female at-risk athletes.
Yeah, I think the first thing to remember is that there's no magic program. There's a lot of programs out there. There's not one that's been shown to be most effective, and all the others are not beneficial. And there's kind of three factors you want to see in a good program. You want to see a dynamic warm-up. We have seen from the literature that static stretching is not helpful for injury prevention, and even hurts athletic performance. So like holding a muscle stretch for 30 seconds is not something you want to do right before you're about to compete. Second piece is the strengthening we talked about for the glutes and the posterior chain, the hamstrings. So some piece of lower body and core strengthening in there. But we know it takes 6 weeks to build up strength. So if you're starting a program on day one of the season, it's going to be beneficial, but you're not going to expect those protective effects until later on throughout the season. And then the last piece is that neuromuscular control. That's what I see in the athletes, whether it's the first time we're having them jump on that knee and land properly, being able to dynamically control their knee. So giving them cueing on the proper mechanics to make them safer as they play and more efficient and more powerful as an athlete. So having those three pieces, but we've also seen that those things can go away. You can practice those proper neuromuscular things and get better at them very quickly, but then if you don't continue to maintain those, you kind of lose that understanding.
Right. Well, we're very lucky. We have an audience tonight that includes many of the athletic trainers and physical therapists that are taking care of our university lacrosse teams here in Baltimore, and a number of members from the lacrosse community. So any questions in the audience for any of our panelists?
I have a question.
Let me get to you with a mic there.
Talking about the femoral notch, and I'm just curious about it. Obviously, replicating a tunnel, and the more narrow it is, the much more easier maybe the likelihood of you to tear your ACL, correct?
Correct.
Genetic makeup, now would you think a big 350-pound lineman would have this big wide femoral notch, or is that not necessarily true compared to a little, 110-pound, 5'2" girl that, or do you never know, you just do not know until you go in, and everybody's notch or any notch could be different, making them more likely to possibly re-tear this thing again, and do you go, we're going to widen this tunnel, but I don't really like the fact that she's going to go play Division I lacrosse and not feel good that she may re-tear this because that tunnel is so narrow.
So I think talking about the notch shape, it's actually a higher percentage of our female athletes that have the narrower notches. So we classify them into letter shapes. So it would be an A-shaped notch, a U-shaped notch, or a W-shaped notch. And so the A-shaped notches are what you're describing as a narrow notch. And so whether that's the ACL is impinging on that notch, it's just something I note in my operative report that they do have a narrower shaped notch. And I feel like with what Milford was describing earlier about an anatomic reconstruction of the ACL, if I feel like I have perfect tunnel placement and the graft was chosen properly, I actually don't worry too much about that narrow notch. They've done some studies, and if we recreate, make a U-shaped notch from an A-shaped notch, it doesn't really change. Later on, it grows back. So you can see a little bit on the MRI, but I'm not too concerned as long as surgically I approach it, but it's something we note in the back of our head.
Okay. Other questions from the audience tonight?
You guys talked about proprioception, doing rehab. When you replace the ACL, are there actually proprioceptive elements to the ACL? And when you replace that with a hamstring or a quad, do those things ever come back, or is it up to all the other muscle groups and other receptors to kind of make up for the ACL that you replaced?
So I think I could speak to that. I think that, yes, there are proprioceptive fibers within the ACL. And I think that, one of the things, that I do during my surgical technique is to actually leave just a little bit of that ACL remnant on the bone. And so that there are still some ACL, we have to remove the patient's torn ACL to put the new one in there. Otherwise, there's too much stuff in the notch and it would impede range of motion. So when we take that ACL out, I'll actually leave a few of the ACL fibers. And that actually does two things. Number one, it helps me target to put the ACL where it should be, anatomically. But then also, when you go back
Milford,
in,
we'll have to leave it with that,
Okay, that's
unfortunately.
fine.
So for you all at home, I think you can understand that the treatment and prevention of ACL injury is evolving. U.S. Lacrosse and its medical partners are active in research and programs development to try to decrease the risk of injury in our sport. Thank you, and we certainly appreciate you joining us tonight, and you can go to the website of MedStar U.S. Lacrosse for further information. So thank you, and good night from Baltimore.